Hello, everyone. My name is David Odeej, and welcome to our medication guide for pediatric muscles, skeletal, and orthopedic conditions. Understanding drug classes is crucial for effective patient care. Each class, from antibiotics to analgesics, has specific uses and safety profiles. Nurses must consider potential side effects, interactions, and patient history when administering medications. This ensures optimal therapeutic outcomes and patient safety. In this lesson, we'll discuss Chapter 29 and the major drug classes used in pediatric osteomyelitis and juvenile idiopathic arthritis, focusing on how each medication works, the side effects, contraindications, and the nursing considerations you must remember for clinical practice and exams. Let's get started. Now let's begin with pediatric osteomyelitis, a condition that requires rapid and targeted antimicrobial therapy. Each medication we use has a specific role depending on the suspected organism and severity. We start with Nafcillin, an anti-staphylococcal penicillin used as empiric therapy for Staphylococcus aureus. Because it's IV, it's part of the early intensive treatment that usually lasts 3 to 4 weeks. As nurses, we must watch for allergic reactions and monitor liver enzymes, especially in patients with hepatic impairment. Next is clindamycin, which is very useful when MRSA is suspected. It can be given IV or orally and is continued for long-term therapy. The biggest risk with clindamycin is C. difficile colitis, so monitor stool patterns closely and educate parents about early signs of diarrhea. Vancomycin, a glycopeptide antibiotic, is used for methicillin-resistant Staphylococcus aureus infections via intravenous over 3 to 4 weeks. Monitor for nephrotoxicity, ototoxicity, and red man syndrome. Avoid rapid infusion, especially in renal impairment. Pediatric dosing is milligrams per kilogram, adjusted by serum trough levels. In addition to antibiotics, many children benefit from probiotics to reduce antibiotic-associated diarrhea. These are given orally during the antibiotic course. They're generally safe but should be avoided in severely immunocompromised children. Always space probiotics at least 2 hours away from antibiotics for best absorption. Moving into juvenile idiopathic arthritis, or JIA, our goal is long-term inflammation control and prevention of joint damage. We begin with NSAIDs such as ibuprofen and naproxen. These are first line for mild disease and are given daily. But remember, anti-inflammatory doses in children are higher than analgesic doses. Watch for GI irritation, kidney impairment, and bleeding issues. Always give NSAIDs with food. The cornerstone for moderate to severe JIA is Methotrexate, our non-biologic DMARD. It's taken weekly, either orally or subcutaneously. Because it can cause hepatotoxicity, bone marrow suppression, and infections, weekly to monthly labs are essential. Educate teens on avoiding alcohol and on using contraception due to its teratogenic effects. Sulfasalazine is effective for axial arthritis, especially in HLA-B27 positive or inflammatory bowel disease cases. Administered orally, it requires long-term use. Side effects include gastrointestinal upset, rash, and liver dysfunction. Avoid insulfa allergy. Monitor complete blood count and liver function tests. When methotrexate isn't enough, we introduce Etanercept, a TNF-alpha inhibitor. It's given subcutaneously weekly or twice weekly. Infection risk increases, so screening for tuberculosis is required before starting therapy. Also avoid live vaccines. Parents must be taught to hold doses if the child develops fever. Infliximab, a tumor necrosis factor alpha inhibitor, is used for refractory juvenile idiopathic arthritis, especially polyarticular cases, administered via intravenous infusion every 4 to 8 weeks. Monitor for infusion reactions and infections with tuberculosis screening required. Adalimumab, also known as Humira, is given subcutaneously every 2 weeks. It's used for moderate to severe JIA and requires TB screening just like the other biologics. Teach parents proper injection technique. Then we have anakinra, an IL-1 receptor antagonist used mainly for systemic JIA. It's given daily by subcutaneous injection. This drug can cause neutropenia, so frequent CBC monitoring is required. Tocilizumab, an interleukin-6 receptor antagonist, is used for systemic or refractory polyarticular juvenile idiopathic arthritis, administered via intravenous or subcutaneous every 2 to 4 weeks. Monitor complete blood count/liver function tests due to risks like elevated liver enzymes and infections. Etanercept, a T-cell co-stimulation blocker, is available as intravenous or subcutaneous. Like the biologics, TB screening and infection monitoring are essential. Finally, glucocorticoids, oral, IV, or intra-articular, are used for rapid control of inflammation or systemic flares. These medications come with major risks like weight gain, high blood pressure, mood changes, hyperglycemia, and adrenal suppression. We avoid long-term systemic use whenever possible. Thank you for your attention. We've explored the intricacies of medication use in juvenile idiopathic arthritis, focusing on specific treatments, their administration, and considerations. Your understanding of these elements is crucial for effective patient care.